Video will be posted on my YouTube channel. So you can, I'm sure, do you have YouTube, Dr. Aimee?
Yeah, totally. Yeah.
So
the Eyvazzadeh show.
Yeah, you could grab, that's right. You could grab it from there. And then it'll also be posted on my Instagram live, but it's easier to watch it on YouTube because you can get the whole thing. When you post it on Instagram live, you have to cut it up. So it's much easier to do it on YouTube. So my YouTube is Shannon M Clark MD. And what is your YouTube?
The Egg Whisperer Show.
The Egg Whisperer Show.
Yeah.
All right, we're going to start. Okay. So I am Shannon Clark. I am a maternal fetal medicine specialist and founder of Babies After 35. I do a lot of things about fertility as well, although that is not my specialty. But due to the fact that I am an OBGYN, so I know a little bit, and I went through multiple cycles of IVF myself and ultimately delivered my twins via egg donor about 10 days shy of my 43rd birthday. Dr. Aimee, who has joined us here, she is a native of San Francisco Bay Area. She has a practice in San Ramon, California. But she is known, and how I got to know her is through her egg freezing parties, which are super popular. And then more recently as the Egg Whisperer. She's on YouTube every Wednesday on your YouTube channel.
Yep, the Egg Whisperer Show. Yeah.
Her mission is to educate people about their fertility health. So thank you so much for joining us. I am super excited about this talk.
You're welcome.
I thank you. I really appreciate you taking your time out of your day to do this for us.
Absolutely.
Okay, so first question I'm going to ask you. And again, I am an OBGYN, but the fertility stuff, the reproductive, all of that used to elude me greatly as a resident. So the first thing I want to ask you is, what is AMH? Everybody talks about my AMH level this, my AMH level that. What exactly is that?
It's a hormone. It's secreted by cells that surround your eggs, and it's normal for it to go down over time. But what can be really confusing for people is it also meanders. So I also call it always meandering hormone. And then the other thing I call it is always mean hormone. Because sometimes when your level doesn't come the way you want it to, people feel like they've now been labeled with something that's low or bad. But the way I think of the test, it's a great way to help you plan your future family, right? So there is no test that will tell a woman she has good eggs or she can get pregnant or she cannot. So for example, if you're 28 years old and your AMH is 0.3, it doesn't mean you have the eggs of a 42-year-old, right? But you should consider maybe freezing your eggs, freezing embryos, so you can secure future options for yourself. Same thing, if you're 40 and your AMH is 0.3, it generally means that, the egg supply is low, but each egg still has a 10% chance of being genetically normal, and age is more predictive of pregnancy outcomes than anything else. So if your AMH is low, I always tell patients low doesn't mean no, right? Consider being as aggressive as you feel comfortable being, and know that you can't control the AMH level, right? Because everyone wants to know, what can I take? What can I do?
Yep.
And I wish that there was some special sauce that we had. These are just diagnostic tools that we use to guide us as far as what treatments to consider, how many eggs you're going to get, and what your pregnancy chances are going to be.
So a question just came in: is there such a thing as an optimal AMH? Go ahead.
I mean, as far as an optimal AMH, there are AMH levels that tell us, you should have around 15 eggs, let's say, if you were going to do IVF, and that tends to give us the highest chance for pregnancy. Certainly there are averages, by age, but, I've had patients who have, let's say, an AMH of 3 at the age of 42 and don't have a single normal embryo. And I have patients who have an AMH of 0.3 at 42, and I get 1 normal embryo, So sometimes patients aren't given that chance when they should be given that chance. So I think it's just important to find a doctor that believes in your fertility. And for me, I believe in the fertility of every patient that walks through that door. No matter how I help them get pregnant, I see them as a future parent.
Okay, gotcha. So, there's no special, what I'm getting from that is there's no special sauce to make your AMH better. It can change. It is a little predictive of what your future fertility might be, but it's not absolute. So I think for me, the key, what I tell patients, even though I'm not a fertility specialist, is it's not going to hurt to get an AMH level. Especially if you're considering delaying childbearing, because it might help some of the younger women decide whether or not to freeze their eggs. And then as you get older, you might want to check it to determine how long you might give yourself to wait before trying. Is that a good thing to say?
That is a good thing to say. I think that, there are some things certainly that can lower the AMH, like a low vitamin D level or being on birth control pills. And certainly taking really good care of yourself and taking CoQ10. That's what I tell patients to do.
We're going to talk about CoQ10 later.
Okay.
Yeah. Okay. So we're going to jump to the next question. So, advanced maternal age, like it or not, and there's a lot of other non-sexy terms that we use to define women over 35, but we won't go there. Right. So is there much of a difference between a woman over age 35 trying versus a woman over age 40 trying to conceive?
I think that there is, and what I have, these things are called egg whisperer golden rules. So I tell people, if you're 32 years old and you think that you want 2 kids, consider freezing embryos if you don't have one already. If, let's say, you're 37 years old and you want 2 kids and you already have one, consider going right to IVF. And the reason is our egg viability changes pretty dramatically. So if I were to just kind of plot it out here, 20, 25, 30, 35, 37, you see how it kind of drops pretty rapidly? And so those are things that we don't even learn in medical school. We don't really learn it that necessarily. It's not something that's ingrained in us when we're OBGYN residents. So I always tell people, you go to your postpartum visit, talk to them about future kids and what you think your options could be for you.
Yeah, I just from my own personal experience, for those of you guys that don't know about my personal experience, I was healthy, a physician, met my future husband at 38, married him at 39, immediately started trying, had a miscarriage right off the bat naturally. I then was diagnosed with melanoma that set me back for several months. So we started trying about 4 months after I turned 40. Again, I was healthy, I didn't drink, I ate well, but after 5 cycles of IVF, 16 of the eggs made it to the testing period for PGS. So we did do the genetic testing on the embryos, and only 1 was genetically normal. So this kind of leads into another question. Can you briefly talk about the difference between egg quality and egg quantity? Because I hear all the time that a woman will say, oh, well, my mom, my sister, my aunt had babies at 57. I'm exaggerating. At 45, at 42. Right. So I will have no problem. I hear all the time that I'm healthy, so I shouldn't have a problem waiting. Right. So talk about that a little bit.
Sure. So my slogans, I'm going to have a whole bunch of bumper stickers. They're not on my car right now, but when I'm 85, they're going to be all in my car. And one of them is, your mom's fertility is not your own. So that's one thing. The other thing is that your fertility isn't skin deep, and it just takes 1 egg, right? Quality, especially over 35, is more important than quantity. And unfortunately, I learned that so much from the IVF cycles that I do, because like you said, you got 16, right? 16 eggs.
So, I got almost 30 total eggs retrieved. We're in the 30s, but the ones that made it to be tested to get PGS, I had 16 embryos. Right. And out of the 16 embryos, 1 was genetically normal. Yeah. Right.
So we all want definitive answers, right? We want to know that if we do this enough, eventually it's going to work for us. But when you're, let's say, over 40, it doesn't work that way. Even over 39, because each egg has about a 10% chance of being genetically normal, right? And it's not one of those things where if I just get 10, that means 1's going to be normal. And then if I get 20, 2 is going to be normal. So what I tell patients is this, think about other options at the outset. Ask yourself, what are you going to do if this doesn't work? And be sure that you're on the same page with your partner, because sometimes the partner can get in the way of your plans.
Yes.
And they can say things like, well, I'm not willing to do this or that. And that can kind of get in the way. And I want patients to be parents. I want them to stop being patients as soon as possible.
Do you have, just along the same lines, do you have, for someone that was, say, over age 40, because more and more women are going to assisted reproductive technology, or ART as we call it. And the ART is a bunch of different things we can do. It doesn't necessarily mean it's not equivalent to IVF. IVF is a form of assisted reproductive technology. So going through multiple IVF cycles, I really think, this is just an aside, I think I went too far. I mean, I was between 40 and 42. I went through 5 cycles, trying to get another egg, trying to get another embryo. And I think things worked out for me the way they should have. But do you, in patients in a similar situation to my own, do you kind of tell them, after this many cycles, if you're not getting genetically normal eggs, you might consider your next plan or next option.
Absolutely. I kind of talk about it from the very beginning. I say, what would you do if this doesn't work? It's really important to talk about it up front so that we feel like it's not taboo to talk about every single way I can help you be a parent. So then it just doesn't feel as scary if things don't work, and they know that there's a plan for them to be a parent.
Yeah.
And that I'm not going to abandon them.
Yeah. Well, I think there are so many options available now. I went through egg donor. There's donor sperm, there's donor embryo there, but every family, every partner, woman and her partner has to determine and have those conversations along the way as to how aggressive or far they want to go, what is okay with them and what's not. And if they don't know enough about it, you're the person to ask, hey, what does this mean? What does donor egg mean? What does donor sperm mean? What does donor embryo mean? So there's so many different options now. And I think it's really important that that conversation is had, especially for women age 40 and above, because sometimes our options are more limited.
Right. And I think people are surprised when they meet us what the chances really are. Like if I were to say naturally, your chance per cycle is around 5% per try, and they're floored by that.
My husband was. I remember we went, my IVF doctor was a good friend of mine. Yeah. And my husband was like, well, even though I had tried to tell him and let him know. So yeah, it's a good, and again, and I also want to put this out there, seeing a fertility specialist at any age does not mean they're going to automatically stamp IVF on your forehead. They're going to talk to you about what your options are, what they think is best for you. They're going to take the whole picture into consideration, or I should say any good doc should do that. And I feel like sometimes women get the misconception that, I'm going to see a fertility specialist, I can't afford IVF. Well, that doesn't mean that's what they're going to recommend, right?
Right. So seeing a doctor just means you're going to be educated about your fertility, and I'm just going to show you my shirt and get your TUSHY checked.
Talk to me about the TUSHY. What does TUSHY mean?
So I find that people don't really know what the simple steps are that they can do to figure out their own fertility. And so I came up with a very simple mnemonic, and it stands for T for fallopian tubes, U for uterus, S for sperm, H for hormones, and Y for your genetics. Those are the basic steps that every fertility doctor goes through to help patients, and it shouldn't be confusing. It shouldn't be hard. It should be very straightforward. And the reason why I came up with this, because I just got so frustrated. I got so sick of patients going through like 12 cycles of fertility pills and not a single semen analysis and no fallopian tube test. And I just said, enough's enough. This was in 2019, and my husband is actually the one that came up with it. I wrote down all the things. I said, honey, these are the things that I do. Give it to me. Give me a mnemonic. And he came up with TUSHY, and he actually came up with Ball's method too.
Well, maybe we'll talk about that a little later.
Yeah.
So, and they can get more information about the TUSHY method where?
On my website, or tushymethod.com.
Tushymethod.com. Okay. Yeah. So there was another question. Real quick. So, eggs do have an expiration date at some point. Yeah. Why doesn't the uterus?
There are some conditions that can certainly make it harder to get pregnant as we get older, and with more periods. And what I'm talking about is endometriosis, right? So with endometriosis, you can also have a condition called adenomyosis, and that's where it infiltrates the walls of the uterus, and that can make it hard to get pregnant as you get older. But in general, for a woman who's, let's say, 45, we just worry about the pregnancy complications, right? Yeah. High blood pressure, early delivery, diabetes in pregnancy. Otherwise, if you take a really strong embryo and put it in a woman who's, let's say, 38 versus 45, the pregnancy rate should be about the same, unless there are other conditions there like endometriosis or fibroids.
Yeah. So the uterus, that's why you hear a lot about the women in their 50s having, even the woman in her 70s, I think it was in India, had babies. The uterus, we won't go there. We can put it out there. The standards in the United States are different.
That's right.
Okay, and I firmly believe in them. We use the American Society for Reproductive Medicine, ASRM. They have great patient resources there if you want to go see for yourself. ASRM, is it .org? I think it's .org. Yeah, .org. Yeah. So we do have different standards in a lot of other countries. But the point I'm trying to make is that, for example, I didn't have any viable eggs, but my uterus worked. Right. So, it has a little bit of different shelf life, I guess you could say.
Right. And just because your eggs have run out, which it does for every single woman in the world. There's no woman that will have eggs for the rest of her life. It doesn't mean your desire to have a baby runs out. And that's the beauty of preparing for pregnancy and using, other options. So you can still do it as long as you have a uterus.
Okay, so what was my next question for you? So what is the IVF attrition pyramid? I've heard about that. And how does it typically look for women over age 35 and then again at age 40?
So I actually have it here. So I'm going to pull it up here. Let me see if I don't know if it's something that you can easily see. Can you see that?
It's backwards, but that's okay.
You get the point. Yeah. So basically at the bottom, what you'll see is you have the number of visible follicles prior to the start of stimulation, right? So let's just make it easy on me. Let's just say it's 10. So if you're 35 years old and you start with 10 follicles, maybe 8 will grow to the end of your cycle and you'll get 6 mature eggs out, okay? Of those 6, the fertilization rate's about 80% and you get 5 embryos. Of those 5, maybe 50% will turn into blastocysts. You're looking at 2 to 3 blastocysts. Each blastocyst has about a 45% chance of being genetically viable. You might end up with 1 or 2 at the end of your cycle. So if you didn't go into your IVF cycle knowing that, you're going to be pissed. Why? Because you're going to think 10 eggs means 10 embryos, because that's what success, because that's how we're ingrained from when we're little, right? We're ingrained that A+ is 100%, but when it comes to human biology, it's completely different. Totally different than anything that we're used to. So that's why I talk about this at most of my new patient visits. I tell patients what their follicle count is based on their age, their hormone levels, and then I talk about what their pyramid would look like. Because for some people, the pyramid might end up being 0 embryos at the top, and that's for women over 40. And I just tell them, you got to just let it go, just like Elsa. Think of this as work and do the work to have the family that you need. And sometimes, like in your case, it takes another egg source.
So, my pyramid would have been, I mean, again, I went through 5 cycles, but again, I think it was 36 eggs retrieved out of the 5 cycles, but only 1 was a genetically normal embryo. That embryo did not take. I did have it transferred, but it did not take. So, I am prime example of someone, and that's why I'm an advocate for talking about this so much. Now, a lot of women don't want to go public with it, and that's perfectly fine. They don't want to talk about their journey. They don't want to talk about whatever they chose to do to get pregnant, especially after age 40 like myself. But giving my position as a physician and what I went through, I really realized, you know what? We got to get the word out there so women are aware, and also to let them know what other options there are out there. And I'll just say this. I'm so grateful that having an egg donor was an option for me, because it did work for me. And I wouldn't have my 2 twins driving me nuts right now. So anyway, along the same lines, let's see. It could take several IVF cycles to get even 1 normal embryo that you said. When do you recommend that a woman consider an egg donor if she's not getting normal embryos?
I mean, I think it just has to do with when she feels like she will have IVF. I call it IVF closure. So I think it's important to feel like you did everything possible to give yourself the best chance for pregnancy. And so I talk about that, and it's different for some people. They want to go through 4 cycles. For some people, 1 is enough. For other people, it's 6, and sometimes even more than that. But certainly, it's such an individual thing. And sometimes working with a therapist can also help you get there.
And I did that as well. I did.
Because like I said earlier, I want people to be parents. I always say that. It's like, I love you, but I don't want you to keep coming in. I don't want to keep doing these egg retrievals. Let's start talking about other options early on. And we can still do things concurrently. And sometimes one of the things that I've done for some of my patients over 40 is, let's say I get 1 normal embryo and I know that they want 2 kids. Well, then we'll maybe consider trying naturally for 6 months, or going backwards with treatment and trying IUI, so that we can use that frozen embryo as an option in the future.
Okay, so I think having those conversations along the way about, it's not like IVF is an endpoint, like you just said, which is I think is a great point. Sometimes you can backtrack and try something else, especially if you're not having a large quantity of embryos that are being being able to have after IVF cycles. So that I've never even, actually, this is the first time I've ever considered that. I've never heard that before. And I think it's a great point to make. So always asking about what your options are and where do we go from here. And, knowing that IVF is not always the end point. Sometimes you can mix and match the treatment.
And, sometimes I tell patients, look, why don't you just look at some egg donor profiles, and you're going to get you're going to have a reaction. And your reaction will either be, oh my God, this feels right. Like, I just want to be a mom. That's the egg donor that I want to use. And I'm really excited about this option. And for other people, it's like, heck no. No. I just want to keep trying like this. And you'll know that when you have that feeling, it's going to be
and
very
I've
real
also
for
had
you.
several women contact me because they initially were like, no, I'm not doing an egg donor.
Right.
A couple months go by and they're like, tell me about an egg donor.
Yeah.
What's it like for you?
Exactly.
And that's fine. I mean, you're always, we're able to change our minds.
Absolutely.
And again, it's not something that you have to post out to the world. Right. It's really your business on how much you want to share. Right. And you don't have to let everybody, I mean, and I've had women who got pregnant through egg donor who didn't even tell their family members. Right. And that's fine too. So it's whatever you feel comfortable with.
Right. I agree.
Okay, PGS, pre-implantation genetic screening. What is it and who is a candidate for, or when is it recommended?
So I recommend it to all my patients regardless of age. I think it's just really important for everyone to know what their IVF options are and then to know what the limitations are as well. I refer to it as the murky crystal ball, right? So what people think it is far from what it really is. It doesn't tell you everything about the embryo. It doesn't tell you about autism and birth defects. It's only looking at chromosomes. It's only looking to make sure that embryo has encyclopedia books A through Z, and it doesn't tell us about the pages. It doesn't tell us if a page is missing. Mm-hmm. And it doesn't tell you if you're going to get pregnant or not, right? It's not everything. So that's where embryo quality comes in. And embryo quality is just as important as making sure that the embryo has normal chromosomes too. So, talk to your doctor about the limitations of PGS, whether they check for mosaicism or not, and whether they're going to report it to you. And then when you do your post-IVF consult, make sure you're talking to them about the embryo quality and have them rank the embryos based on the quality so you know what the implantation rate is for each embryo.
Okay. And actually, there might be a whole nother talk about embryo quality. Maybe we can do this as a next one, because I know I get a lot of
great.
I can't answer any questions about that, and I won't even pretend to, but I'm sure a lot of people in my audience would love to hear, because they're always asking me, and I'm like, is that what I do? I don't know the answer. Yeah. Okay, so let's see. If I know but you are. There was another question here. So, but you aren't. I think we kind of the question was, what do you do if you've run out of options with IVF due to egg quality, but you aren't ready for other options? So we kind of talked about it a little bit, but what can you do if you're not ready for other options?
Just give yourself time. Talk to a therapist. Build your team. And I tell patients to build their team from the very beginning. The T is therapy, exercise, acupuncture, mindfulness, and meditation. Build your own mind-body center if you don't have one at your fertility clinic. Yeah. And just give yourself space. And eventually the answer will come to you. Mm-hmm. And if you want a mom, if you want to be a mother, you get to that point where DNA is far from what's important. We're on this earth for such a small amount of time, and especially with what's going on in the world right now, people are realizing it more and more. Yeah. And I'm so excited about our future because so many people still want babies despite what's going on. Yeah. So I feel like it's that much more important I feel like what's happening in the world is making us realize how important family is. Yes. And there's so many ways of being a family.
So I'm going to backtrack for the PGS question. Yeah. Is there, according to the guidelines you guys use across the centers in the U.S., is there a certain age above which PGS is highly recommended? I know because it is an extra cost. I know women don't have to do it. But is there a certain age where you say, you really need to consider doing this?
I think that every clinic will have their own philosophy. Mm-hmm. Like I've had clinics say, well, you're only going to get one blast if you're lucky. Why put it through PGS, right? My philosophy is, because there's only one, of course you want to put it through PGS. I don't have the time to have you have a miscarriage and then waste 4 months of your fertile life finding out that a pregnancy is abnormal and didn't grow to then have to go do more IVF cycles. I want to know that up front. Mm-hmm. So I think knowing the strengths of your lab and then talking to your doctor about what your fears are about it. But I certainly think that, especially if you want to have more than one baby banked, as embryos for the future, you want to know that the embryos that you have stored for yourself are going to give you that chance for pregnancy in 2 or 3 years. So that's why I think PGS is something that everyone should consider, but especially for women over 35.
Okay. All right. Let's see. So women are getting pregnant after menopause.
Yes.
How does that even happen?
Yeah, I call it menopausal pregnancy, and it's because you don't need fallopian tubes, you don't need ovaries to have a baby. I mean, we literally could do a male uterine transplant. I mean, it is possible, but we're not going to because society doesn't need us to, right? And so as long as we have, other options like egg donation, or if a woman had frozen her eggs, let's say at 36, and now she wants to have a baby at 48, she can use those eggs. And then we prepare the uterus in the same way that we prepare a uterus for frozen embryo transfer. So we can mimic ovulation with hormones, estrogen, and then estrogen and progesterone, and then do a transfer, put an embryo inside a uterus. So you don't need ovaries or regular periods. And I think that shocks a lot of people because they feel like egg donation isn't an option for them because they don't have periods anymore. So that's why I talk about.
Well, that goes along the same lines, about the uterus not being held to the same constraints that the eggs are, and the uterus can be used as long as everything's okay,
Right.
with the anatomy and things like that, that the uterus can be productive, if you will, later in life. So, so that's important to know. So that is I guess I didn't even consider calling it a menopausal pregnancy, but that's what it is. The other thing to know is that, yes, once a woman, if she's not making the hormones biologically because of her age, you guys give them what we call exogenously, through the injections or whatever that you're getting until a certain point. And then I don't know if a lot of women know this, but you don't have to continue that because the placenta takes over at some point. So that's why you need all that from the beginning, but then at some point that all stops because the uterus does take over. I'm sorry, the placenta. So and then the placenta produces all the hormones. Right. Okay. We talked about that. If a woman cannot afford IVF treatments, what supplements can she take? Let's talk about that. If a woman cannot afford IVF treatments and she's trying to get pregnant, actually, before we answer that question, I just thought, so when we talk about, if you're over age 35, waiting 6 months, if you're over age 40, waiting 3 months before seeking help. But there are a couple of things that one thing that I talk about, as long as you're having normal menstrual cycles, right? If you're not, and you're over age 35 or 40, you may not want to wait even that long because you got to kind of figure out why you're not having normal menstrual cycles. Would you agree?
Absolutely, because the reason could be that you either have too many eggs or not enough eggs, right? And if someone just assumes it's because you have a very common condition called PCOS and you later find out that you had not enough, then you'll be pretty upset and rather frustrated that no one, did a simple test for you. And that's the AMH test that we talked about at the very beginning. And obviously you need to be ovulating to be able to get pregnant. So if your cycles are spaced out, again, it's super frustrating to track when you're ovulating and checking an ovulation predictor kit or checking your temperature can get really old really fast.
Yeah. So that means, the 6 month rule over age 35, the 3 month rule over age 40, that's assuming that you're having normal menstrual cycles. And having normal menstrual cycles means the days in between and the length of each cycle are pretty consistent. And that is an indicator that you are likely ovulating. If that's not the case, then you may want to seek help or talk to someone sooner than later, sooner than the 3 month, 6 month rule.
Exactly.
So back to the question. So if you can't afford IVF treatments, what supplements can you take?
Well, I mean, I think that if you can't afford IVF treatments, there are always other options, right? So back to the TUSHY, like making sure your tubes are open, your uterus is healthy, the sperm is good, your hormone levels are good, and the genetics are, where we need them to be so you're not, potentially passing on a disease like cystic fibrosis.
And by genetics, you mean the genetics of the mom and the dad?
Correct. The egg source and the sperm source to make sure that they're genetically compatible. I think that's important to do at the very, very outset. Taking CoQ10 is something that I think every woman should start, even in their 20s. I think that, people have this idea that supplements take 3 months to work, but with CoQ10, it could be like 8 years to see a benefit. So as soon as I meet, let's say, an egg freezing patient, I tell them, start your CoQ10 now, right? And I even have my egg donors take CoQ10 when I'm cycling them. And then certainly when I meet patients for their new patient visit, if they're not on it already, I have them take it. But the things that you can do on your own would be to make sure you have a healthy body size, that you're doing everything in moderation, like alcohol, exercise, coffee, and then make sure that you're timing intercourse correctly. And then there are other lower cost options. And, some centers do offer something called InvoCell. So InvoCell is where you extract the eggs, you put the eggs and sperm in a little vaginal chamber, and that chamber goes in your vagina. And the pregnancy rate is about 10 to 15% higher than an IUI cycle. So that might be a good option for someone who can't afford IVF. And then the other thing is shop around. So for me, I just want to help people, whoever comes to me. I don't necessarily need to be their doctor. And so sometimes people think that they need to leave the country to do IVF and to be able to afford it. But if you look at, for example, in Oregon, the cost of living is 20% less than the cost of living in San Francisco. So of course the IVF fees are going to be lower. So if you're living, let's say, in the Bay Area and you still want to do IVF and stay in this country, ask your doctor, because I certainly know where I tell patients to go, where it's going to be a little bit more affordable.
Okay, so we just had a bunch of questions. So about CoQ10, number one, how long can you take CoQ10, and what is the dosage?
I tell patients to take 300 to 600, and that they can tolerate it even up to 900 milligrams.
So are the pills 300 milligrams each?
It depends. You can get 200, 400. Typically they're around 100 to 200 milligram tablets.
So you recommend, what you said, 300 to 600 milligrams a day?
Correct.
Okay.
And then you can get it in the form of ubiquinol. So ubiquinol typically comes like 175 to 250 milligrams, and you would take 1 to 2 of those. One of those tablets is almost equivalent to closer to 500 to 700 milligrams of CoQ10.
Okay.
So just see the type that you're taking, and then talk to your doctor about the dosage. So when you see the serving size instructions, for example, on the bottle, sometimes they'll say it's 1 tablet, but then I tell my patients take 2 or even 3. Okay. But talk to your doctor first before you do something like that.
Okay. And let's see, what's the other thing? Okay. So I'm going to do this last question with you, and then we're going to go through some questions that we have from the audience. So let's talk about what's going on right now with COVID-19 and the recommendations that came down from ASRM regarding fertility treatments.
Yeah. So ASRM made a recommendation for all treatments in this country to basically stop unless they were for an emergency. For example, in my world, having cancer is an emergency diagnosis, right? Where someone needs to go through chemotherapy, then that's the type of cycle that some people are still going to start right now. Otherwise, all treatments have stopped. Frozen embryo transfers have stopped in most centers. Ovulation induction cycles have stopped, as well as IUIs. And it's not so much because pregnancy is dangerous. It's because of resources, as people have probably heard, getting masks, getting gowns, ventilators. We might be looking at shortages in different areas. There already are shortages of masks and other PPEs out there.
Yeah, so I've been telling patients it's from what I understand, the recommendation from ASRM regarding fertility treatments is twofold. The first being that, of course, we don't know what the ramifications are for COVID-19 and pregnancy, of course. And I say that for women that are trying to conceive or women that are pregnant now. Second is, like you said, for resources and, decreasing exposure of the patient and the medical team for what's considered elective procedures. And unfortunately, advanced maternal age or older maternal age and diminished ovarian reserve, which comes with advanced maternal age, are not considered urgent conditions. So they're not covered under these new guidelines for the time being. So that's kind of what's going on with ASRM. But hopefully that won't last too long and we can get back to normal.
I agree. And so what I want to tell people is there's no emergency. There's no reason to lose hope. Waiting 1 or 2 months, nothing bad's going to happen. So use the time to prepare, find yourself truly.
Yeah. So what do you think about acupuncture?
I think acupuncture is a great adjunct to fertility care because patients feel better. They actually have less side effects, less nausea, less pain. They recover better from their egg retrieval. And I tell my patients, I say, go to the acupuncturist and say, please give me, make my eggs look good for Dr. Aimee.
Yeah.
But at the end of
So for my own story, I am the evidence-based academic physician. And I was like, I would always see there was a brochure in my REI's office for acupuncture. And I was like, whatever. I did not believe in it at all. And after going through 5 cycles, and then we finally decided to go to donor embryo, I was like, you know what? I'm just going to do it. I'd already failed to a transfer of my own, the one normal embryo I had. I'd already failed a transfer of 2 donor egg embryos. Right. So I did it for about 5 months before we transferred the second 2. Mm-hmm. And I don't know if this is what ultimately helped me to get pregnant, but I will definitely say it did decrease my stress level.
Yeah.
Being a physician, I was stressed out and going through what I've gone through. Right. So I do, and I do think there's something to be said for that, because stress can be a really bad player in all of this. Yeah. So we got to do what we have to do to try to minimize our stress.
Right. And the acupuncturists that are fertility minded, they're great listeners, and they're just going to be there to support you and cheer you on and just be another part of your team. Mm-hmm. Will they help improve egg quality? I don't know so much about that, but I feel like if they're going to help with your stress, then certainly there could be an aspect where you might see some improvement.
Yes, I definitely agree with that. Yeah. Okay, so let's go to some of the questions. Okay. Let's see. I'm going to answer this. How to get the eggs to grow at the same rate? Any other option other than taking birth control or estrogen, and is one better than the other?
Yeah, every egg will grow at a different rate. Not every egg is going to be viable. So that goes back to my IVF pyramid. Mm-hmm. Every cycle will have a certain number of mature eggs that you're meant to get out of it. And so my strategy is to see patients frequent and early during their IVF cycle. So I will sometimes see patients even after 3 or 4 days of stim to see if I should increase the dose or add the antagonist early on. I prefer natural cycle starts for lots of reasons. I personally don't like birth control pills, but there are some really good indications for using birth control pills, like planning your cycle, and women who have a really high number of eggs. Mm-hmm. But in general, trying birth control pills is one way to get them to grow, all at the same rate. But my concern for women, especially over 40, is that it can also suppress your ovaries and cause you to have less eggs and then need more drugs, and then you're spending more money. So that's why I like to do cycles in the way that I do them.
Yeah, good answer. So another one. Why is thin endometrial lining a concern when progesterone can be given until desired thickness is achieved?
You need a nice landing pad for that embryo. Yep. And so studies show that having a nice thick landing pad with a certain texture, and we call that the trilaminar texture, mm-hmm. gives patients the best pregnancy rate. So that's the reason why. Yeah.
Let's see. Is it a safe time to do frozen embryo transfer or retrieval? And the answer to that is right now, we can't initiate new cycles. So, right. Mm-hmm. So the answer to that is, it's not whether or not it's a safe time, it's whether or not you're able to do that. So right now the answer is, it's not a matter of safety. It's just that we're not allowed to do that. Correct?
Right. And it's not so much about being allowed. Certainly there's some parts of the country that, they're not as affected as other parts. Right. Okay. And so there are some doctors that are still finishing up the cycles that they had started, 2 weeks ago. Mm-hmm. And there are some patients who sadly were canceled during their IVF cycle. I think it just has to do with what's going on in your community.
In the specific area, right? Yeah. And what was the second part of this question? Can you pass COVID to your eggs or your baby? So I'll take that question. Well, as far as the baby goes, based on other coronaviruses, namely SARS and MERS, mm-hmm. there was no indication with them of vertical transmission. Vertical transmission means where the mom who has COVID-19 or has the coronavirus or a type of coronavirus can pass it to the baby during pregnancy or during the delivery process. Mm-hmm. However, this is a novel virus, and we don't have enough data to know that. We've heard one small study out of China that said there was no indication that there was vertical transmission in COVID-19 positive moms. Then we heard that a baby was born with it. So we don't know is the answer to that question. As far as whether or not you can pass it on to your eggs, I'm sure the data is not there for that at all, right?
And you probably can't. If you look at other viruses, like, for example, HIV and Hep B and Hep C, you're not passing it on to your baby from an egg retrieval.
Yeah, right. So I think the safe answer to the one to the eggs is likely no. To your baby, we don't know. We don't know. We just don't have enough data on that. Right. Yeah. If you're pregnant, and you get it. So yeah. Right. The answer is we don't know to that one. Yeah. See, what would you have changed? There's another question about how to get the eggs to grow at the same rate. Yeah. Yeah. Let's see. got rid of that question. I'm trying to knock them all off. Let's see if there's anything else. So actually, I'm going to go through and answer some of the audience questions if you don't mind. Perfect. Okay, I'm scrolling through. Let's see some of these questions. Bear with me. We're going to do this for about 10 minutes, and we're going to close with some more coronavirus info.
Yeah, I love how my face is the exact same color as my drapes. I match it perfectly. Yeah. You coordinated.
Okay, hold on. I'm trying to get to this. Okay. Any recommendations for recurrent miscarriages? Is a long-term baby aspirin advised for a 43-year-old? So there are specific recommendations for when low-dose aspirin is recommended. Age alone is not really one of them. You have high-risk categories and low-risk category, high risk and moderate risk. And so I don't know what your history is, but you should definitely talk to your obstetrical care provider, because ACOG has issued really specific guidelines regarding who is a candidate for low-dose aspirin. And low-dose aspirin is 81 milligrams a day. So, and ideally started around 12 weeks of pregnancy, not before then. So if you have questions, again, ACOG, which is the American College of Obstetricians and Gynecologists, has issued very specific guidelines. There's a table. You can even Google it. If you Google low-dose aspirin in pregnancy, ACOG, it'll tell you that it'll give you the table. So then you'll know where you fall into those categories. We already talked about AMH. Is it okay to continue taking supplements during IVF treatment?
I say yes, absolutely. I tell my patients not to stop until we have all the embryos that they need for the family sizes they want. That's my approach. Mm-hmm. I know there are some doctors who ask their patients to stop supplements at the start of stimulation, but that's not my guidance.
Okay. And there was another question that came through about DHEA.
Yeah. DHEA can help some patients. I think it can help patients who have a low egg count potentially grow the follicle count maybe by 1 egg, maybe. But you have to be really careful with it, because it can also cause your testosterone levels to rise. And we know that high testosterone levels can also be bad, right? And I've actually had one patient who had irreversible voice changes from it. Mm-hmm. So if you're starting to get acne, hair growth, really oily skin, then you might want to stop the DHEA. And then depending on your body size, you may not want to start at the dose that most people take, which is 75 milligrams. Start at 25 and then slowly go up. And then monitor your testosterone levels every month to 3 months.
I also want to put this out there too, and this is with any medical condition, but especially in pregnancy and going through fertility treatments, because I know I see it when they get on the internet and they hear this in this group, take this, take that. You should definitely let whoever's taking care of you know what you're taking into your body. If it's anything in a pill form out of the bottle, or a certain tea, or certain, anything that you're taking that's not normal food or water or drink, mm-hmm. they need to know what you're taking, because they may, as Dr. Aimee just said, they may have their own personal views or opinions on what they like and what they don't like. So if you're spending the money to go through these cycles of IVF or any other fertility treatment, it's better to be completely 100% transparent as to what you're taking. Right. And don't, I would say doctor shop, but that's what I mean, but don't pick and choose who you're going to listen to as far as what you're taking. You got to decide that you're going to trust your whoever's taking care of you, mm-hmm. and what they recommend, because it's really important. As a maternal fetal medicine specialist, sometimes I am pretty surprised about what women are taking, and I'm like, you might want. We need to stop doing that. But I heard in this social media group that I need to do this, or 2 baby aspirins are better than 1, and the answer to that is not always true. Right. So we got to we got to let our doctors know what we're taking. Mm-hmm. Question. So IVF is pretty much a must over age 40. Is that true or not?
Mm-hmm. I don't know. There are some people who find themselves pregnant as they're getting ready for their IVF cycle. Mm-hmm. There's some people that get pregnant as they wait for their transfer. So you don't need IVF to get pregnant. And the other thing is that IVF doesn't always help you get pregnant also. Mm-hmm.
Right. And I one of the things I always caution women who are anticipating delaying childbearing, and I hear this all the time, well, if I don't get pregnant on my own, I'll just use IVF.
Right.
You can't consider IVF a plan B, because number one, it may not work. IVF didn't work for me.
Right.
egg donor work for me, donor egg work for me.
Right.
But that was also a lot of money and a lot of time. So you can't just go through life that way, especially at younger women. I hear that all the time, and I'm sure you probably do. Oh, well, if I can't get pregnant on my own, I'll just do IVF.
Right.
So you have to be informed, and if you are anticipating delaying childbearing for any reason, and typically delaying childbearing means until after age 35, and especially after age 40, you need to start having those conversations with your obstetrical care provider or your OBGYN so they know what your plans are. As you start to approach 34-ish, even see an REI or a reproductive endocrinology and infertility specialist, just to let them know what your plans are so they can give you some guidance. There's nothing wrong with that. Right. Being informed and knowing what's going on with your body and what you can be doing in the meantime is so crucial. I think we highly underutilize those visits just for information. All of the doctors, maternal fetal medicine specialists, OBGYNs, fertility specialists such as yourself are always willing to talk to women in consultation, just to say, hey, what are your plans for childbearing? Right. Exactly. What are you wanting to do with your life? Right. And we do need to I do always recommend that women take advantage of those visits.
Yeah. And just remember, test, don't guess, don't make assumptions, and don't worry that you're going to find out that you're not fertile. You might find out you have a fibroid that needed to be removed, and thank goodness you found out at the very beginning. Mm-hmm. Those are important things to learn about.
There was another question that came through. Woman's 42, a husband is 43. They're healthy. She was going to a fertility clinic because she was concerned about her egg quality. Her AMH was good. She didn't tell me the number. Now the clinic has closed. We now want to try naturally, which I think is great. Any suggestions?
Yeah, I mean, I have like a checklist where it's like, if you have a history of an ectopic pregnancy, maybe don't try right now. If you have a history of having hyperemesis, which is where you're throwing up all, things that might require a hospital in the near future, maybe hold off on trying. But otherwise, just timing intercourse around your ovulation every couple days. If let's say you're ovulating typically around day 12, maybe start having sex day 9 and then have sex every other day until day 14. That's the best way to do it.
So I along the same lines, what I have been telling women who have reached out to me is this, because of the current situation with COVID-19 and sometimes it can seem pretty bleak. And I get it. All of us are concerned about the unknowns and the what ifs. But for women who are actively trying to conceive, I think they need to put in one hand what we don't know about COVID-19 and pregnancy, along with if you do get pregnant, that your access to prenatal care may be restricted, because a lot of the OB centers across the nation or OB obstetrical care providers are limiting how often they see patients, when the first visit is, when how many ultrasounds they get, how many any of the other testing they get, because we're trying to keep patients safe and healthcare providers safe. Right. Number one, of course, is to keep patients safe and not exposed. And number two, if we expose a lot of providers, healthcare providers, and they start getting sick, that it will even further restrict women's access to care. So you have to put that on one hand versus the consequences of waiting. If there really is not a major time factor for you, and you can easily hold out, then you might want to wait for the time being. But if you don't know and you need a second opinion, talk to a physician. And we can do this through telemedicine if you can't see the doc. Are you doing telemedicine visits?
I'll telemedicine visits right now. Yeah.
Right. So, I mean, a lot of us are doing it. Again, as Dr. Aimee had said earlier on, it depends on where you are in the country as to how restricted certain visits are. I know where I work, we're very restricted. Pretty much everything is telemedicine. Now, if you're pregnant or you get pregnant and you have other medical conditions that need attention, nobody's going to deny you that. Right. But, if there's any way, you still have to consider that if you're actively trying to conceive during this time.
Right.
Let's see if there's any other questions. Oops. Sorry, I'm still here. Let's see. Someone said they miss you. Hi, Dr. Aimee. I miss you.
Hi.
We already talked about PGS. I just turned 39 and had my first pregnancy and miscarriage. Is this common? I can answer that. Yes, I was 39 and it happened to me. Yeah. My first pregnancy and I had a miscarriage. So miscarriage as a first pregnancy or any miscarriage is more common than women realize. It's common. Do you have anything to add to that?
Yeah, no, I mean, I think when you have a miscarriage, sometimes people are given bad advice, like, oh, just keep trying. Because you had a miscarriage, that means you're going to get pregnant easier the next time. And I think it's the opposite. You had a miscarriage, get your levels checked, go talk to a doctor and see what's going on and see if there's anything that can be done to prevent another one. And often the answer is there's nothing that can be done, but you want to learn what you can from that miscarriage to see that, you know, there's nothing that you can do that prevented it, like remove a polyp or a fibroid or something like that.
Right. I would also add in that if you do have a miscarriage, especially at an older age, if you have the time and it's available to get the genetic testing of whatever, tissue or whatever that we can, because that is sometimes helpful. So just always keep that in mind if it is a possibility to consider getting testing.
Right.
Okay. What about minimal stimulation IVF? Have you seen success, better quality of eggs doing this?
I always tell people more is always more, right? Less isn't more, but if you have less, you got to just work with what you have. So I know that there are centers out there that say that, low dose stimulation is the way to go. But I can tell you, if you're someone who has 10 eggs and the doctor gets 2, you're going to be upset. A lot of people, if you didn't understand that the goal was to get 2 eggs, you're going to be like, well, I could have gotten 10 and I only got 2 and I wasn't successful. And that's really frustrating. And so at the end of the day, it is a numbers game. So if you have 2 or 3 eggs, then mini stimulation is the way to go. Like, why take standard stim just to get 2 to 3 eggs to grow? But if you have 10 follicles, my recommendation is, especially if you're over 40, try and get all 10 eggs to grow, because that'll give you the best chance for pregnancy.
Yep. New patients before starting, is she recommending COVID-19 test? So new patients before starting, is she recommending COVID-19 test? I think the question is, and I could be wrong, but I think the question is before starting, trying to conceive or maybe starting a fertility treatment, should you get COVID testing? You should be giving COVID testing if you have risk factors, exposure, recent travel, symptoms, any of those. We shouldn't just blanket test everybody for a couple of reasons. Number one, it should be indicated when you get the test. And number two, for resources. Okay. Anything to add to that?
I agree. I mean, when you have to ask what are you going to do with the information? And, right now we're not going to do anything because we're not starting stim on anybody. So knowing what the results aren't going to help.
Another question. As so many of us, my transfer was canceled and I stopped all meds and got my period. Will I ovulate this cycle after coming off these meds? Can we try naturally?
Yeah, it just depends what meds. So for example, if you were in a frozen embryo transfer cycle and you were on estrogen, and then you stopped the estrogen and your period came, then you should expect an ovulation if you're used to having regular cycles about 2 weeks later. Same thing with IVF meds. Once you stop them, let's say you were treatment day 5, you're going to ovulate maybe 4 or 5 days later. Your period's going to come 2 weeks later. And same thing, your ovulation should come around the same time after that period starts.
Okay, good question. Let's see. Do we know if I can connect? So again, one of the people just joined probably after we address this, but we know if COVID-19 can affect embryo or fetus like Zika virus. So at this point, the answer is we don't know. There's not enough data, and I don't know when we will know. Zika virus is something that everybody worries about, but that had been going on for quite a while when we realized that it was affecting the baby, and that's how we knew. For this novel virus, we don't have enough information. If you consider that it's similar to other coronaviruses like SARS and MERS, there may be no increased risk of pregnancy loss. The main thing with COVID-19 or any serious illness or virus in the first trimester or early in pregnancy is a high fever. A high fever we do know is associated with birth defects. So, and that can be with any illness. So right now, what we can definitely say is high fever with COVID-19 in pregnancy, early in pregnancy, can have effects. There are women who have had COVID-19 who have delivered early. We don't know whether it's specifically because of the virus or not. But any illness, viral illnesses, especially with the flu, we do have more women with the flu who delivered early. There's just not any definitive answers regarding COVID-19 and pregnancy because we just don't have enough info.
Right.
Okay, so somebody just wants to thank us both so much for your time and knowledge, and she loves us. Everybody says thank you. So I think I'm going to stop the questions because there's a lot more, and we have 5 more minutes. So I know, Dr. Aimee, you wanted to talk a little bit more about at the end about you have a blog coming out soon.
Oh, I was going to just a blog on COVID-19 and pregnancy. That's it. It was just going to be an article that I was going to post.
Where will that be located?
On my website, on the draimee.org.
Okay, so you could find that. I kind of saw a little preview of it, so it'd be a great place to get some compact, accurate information. So you can go there for pregnancy, and if you want to tag me on it, I'll share it on my website as well.
Thank you.
So I realize you guys have a lot of more information, and hopefully we'll do another one of these to answer some more questions. But Dr. Aimee, I do appreciate your time. I want to thank you for this because I think it's a really good talk. And if you guys have any recommendations for future talks, we'll be open to that as well. You can message us. I'm just going to give you my social media and then followed by Dr. Aimee. Where you can follow me on social media is obviously on Instagram at Babies After 35, Facebook at Babies After 35. Also the YouTube channel on Shannon M Clark MD. And you can also email me at info@babiesafter35.com. This video will be posted on Instagram for 24 hours. I have not been able to figure out how to save it to my Instagram live. There's a way to do it. I haven't figured it out yet. So what I usually do is videotape it from my husband's phone and then post it on YouTube. I think there's a limit as to how you can save it to your camera roll. I don't know. I'll figure it out. It'll eventually be posted on my YouTube channel. So you can go there to watch the whole video as well. Would you like to share your social media websites? Oh, and then also there's babiesafter35.com. So go there.
Yeah, so eggwhisper.com, draimee.org is my main website. And then Egg Whisper on Instagram, and then the Egg Whisper show on YouTube. And I'm always happy to answer people's questions. You can see on YouTube, people ask me a lot of questions, and I always answer them.
Do you do live YouTube, or you do?
I do live every Wednesday, and then they get stored on the channel.
Awesome.
Yeah.
Cool.
Yeah.